cardiomyopathy, and the diagnosis and treatment for the progress on the hypertrophic cardiomyopathy. For the definition of hypertrophic cardiomyopathy is a little different in different guidelines and consensus. This is the definition from the 2022 Chinese guideline that shows the HCM is an autosomal dominant primary cardiomyopathy caused by pathogenic variants in genes encoding cardiac sarcopenia-associated proteins, corrected by thickening of the ventricular wall. And the HCM is an autosomal dominant heart disease, and nearly 30 to 60 have an identifiable pathogenic or likely pathogenic genetic variants. And in the AHA guideline, that recommend the target gene contains 8 sarcomeric genes as the first line detection. Among the patients of HCM, the 2 most common genes, which MYH7 and MBP-C3, identified in nearly 70% of variant-positive patients, while others each account for a small proportion of patients. And multi-studies from the worldwide have reported the very similar prevalence of hypertrophic cardiomyopathy. And in China, the prevalence is about 0.16%. And in Japan, the similar prevalence HCM in the common population. And the main molecular mechanism basis for the HCM is the increased number of automyosin complex is responsible for the increased contractility and impaired relaxation. And the clinical profiles and prognostic pathway is very different. And the personalized profile for the HCM include the sudden death, the progressive heart failure, and advanced heart failure or end stage of heart failure. And for the arrhythmia, the most is atrial fibrillation, which also can cause the stroke. So the individual patients may progress among one or more of these disease, but along 2 or 3 pathway in only 10% of the patients. So this shows the incidence of different outcomes, such as the nearly 43% have the progressive heart failure. How to make the precise diagnosis of HCM? In the real world, nearly 90% of HCM are undiagnosed, and only 10% of the HCM are clinically diagnosed. And this is the reason for the low diagnostic rate of HCM, because the HCM in some patients are asymptomatic or have only mild clinical symptoms or mild morphological changes. And the HCM is symptoms is very different, and the diagnostic modalities of HCM are inadequate or underapplied. In the AHA-ACC guideline, make the recommendation the following items for the diagnosis of hypertrophic cardiomyopathy. The first is the ECG. More than 90% of HCM patients have ECG abnormalities, which may predate the detectable histologic or anatomical changes. And the ECG abnormalities include the Q-wave and the QRS complex, and also the repolarization abnormalities or the QTC prolongation. The echo is the main and plays a central role for the diagnosis, condition evaluation, and treatment selection, and the treatment effect evaluation for HCM patients. And the echocardiography provocation test or exercise stress test are used to screen for acute obstructive hypertrophy cardiomyopathy. So according to the hemodynamic typing, the HCM divided into obstructive or non-obstructive. And for the obstructive also include the resting of obstructive or the acute obstructive, which means after the exercise, the LVOTG is more than 30. So nearly 30% of HCM have acute or obstructive HCM, but it is often not well identified. So the exercise echo includes the physiologic provocation or exercise stress or the drug stress, which give the very detailed recommendation in the guideline. The MRA is also for the patients with HCM, also can give very more information beyond the ECG and the echo. It can give the some evaluation for the LGE or other morphological changes, including the EF or the developing of apical aneurysm, or make a very different diagnosis for the alveolar thickness disease. So this is the flow chart for the genetic testing and family screens for the HCM. We also published the China HCM guideline 2022, and this is the evaluation and family screening flowchart in this guideline. All the HCM we can make the recommendation to test the genetic variants, which according to the degree we can find the P or LP variants for HCM, and then combined with the ECG, echo, or MRA, we can make a very detailed and precise diagnosis. So we also to make the differential diagnosis for the ventricular wall thickening disease. For other cardiomyopathy also include some other disease, such as the Fabry disease or the donor disease or the amyloidosis, which include the AL and ATTR type. So we need to combine all of these ECG or echo or MRA or the genetic test or other the characters. We can make a very precise differential diagnosis for the thickened for the ventricular wall thickened disease So this is also the recommendation from the JAG paper, also include all of this diagnosis method. So this is the optimized diagnostic algorithm from the HCM guideline in China. So we first give the patients for the test according, including the ECG or the echo, and then to give the MRA, because in China the is not very expensive, but in some time it is very very busy and not be to be taken not very maybe need a relative long time, and we need to find the family history for each HCM patients and to give the genetic testing and find if the patients have carrying the P or LP genetic variants for HCM. The third part is on the treatment of HCM. The treatment goals for HCM include to relieve the clinical symptoms, delay the disease progression, and reduce death and improve heart function. For each treatment part, we should have the goals for each part. The most important is to reduce the LVOTO for the obstructive HCM, and if the patient have the heart failure, we need to divide it into the HFrEF or HFpEF, and also have to treatment for other comorbidities such as the atrial fibrillation, the thrombosis. For the pharmacologic treatment for HCM, which we can divide it, the drugs such as the LVOTO related symptoms, we can use the beta blocker and the CCB. For the heart failure, if the patients have the HFrEF, we can just to according to the HFrEF GDMT treatment. Although there is no robust evidence for the HCM patients, we can to give some the low dose of a RAS inhibitor or MRA or diuretics according to the EF value or the symptoms or the LVOTO gradients. And if the patients have the arrhythmia, such as atrial fibrillation, and we can give the heart rate or the rhythm control or the anticoagulation. For the non-pharmacological treatment, which include the ventricular septectomy or ventricular septal alcohol ablation, and for the patients have the arrhythmia or have the arrest, we can give the recommendation for the CRT or CRTD. So this is the recommendation treatment strategy from the AHS. And for the patients with obstructive HCM, if the pharmaco treatment is not cause the symptom relieved, so the SRT are considered. The SRT is generally reserved for patients whose symptoms are not relieved by medical treatment, but the surgical is very not be taken on some hospitals. So and a certain number of medical centers cannot taken the SRT for HCM in China. So there is a large unmet need for this kind of patients. For the ventricular septal alcohol ablation, because there is short of evidence for the long-term outcome improvement, so it is not recommended to consider it as a conventional treatment option after a poor response to drug therapy. There is a huge unmet need for HCM treatment from the patients. This is a registry study which collect the symptoms or the reflection of the patients. So for the treatment help to improve the quality of life, nearly 50% of the patients think it is about just a little improvement, and nearly 25% just a lot improvement. So there is a huge unmet need for the treatment of HCM. In recent years, there is the new therapy for HCM, such as the new surgical method and the new drug treatment or some kind of gene therapy. For the surgical modalities, which include the such as the apical myectomy, transcatheter mitral valve repair, or some new drug just such as melphalan or africatin. So for the melphalan, this is the first myosin inhibitor, which approved by the FDA after several trials come out. The melphalan just targeting cardiomyosin ATPase, capable of reducing the formation of actin myosin cross bridges. It is a small molecular drug designed to reduce the myocardial contractility at the sarcomere level, and it is reversible. That means if the drug is stopped, it maybe can cause the reversible of the LVOT gradient also increase, and also if the have the EF reduction, just to stop the drugs, and the EF may be recovered, and it is myosin specific. So there is some trials such as the Explore HCM trial, which include the 251 of LVOTG more than 50, and the New York Heart Association about 2 or 3 class, and the treatment duration is 30 weeks, and the result shows the melphalan compared with placebo can improve the peak VO2 or improve the symptoms and reduce the VOTG gradient. And for the MAVA LTE is can to extend the Explore trial to nearly 62 weeks, and showed that the effect is persistent, and the safety is very good. And the Valor HCM trial include the 112 SRT HCM patients, and the result shows after the 16 weeks treatment compared to the placebo, the mavacamten can reduce the need for the SRT. And another new drug is the aprocitentan. And compared to the mavacamten, it have some the optimized plasma half-life about 3.4 days, so it can be used once daily, and can be rapid reversibility, and also have a wide therapeutic window, and no need for the peak guidance dosing. And also no significant CYP inhibition or induction. The Redwood trial is the aprocitentan compared with placebo, and the result shows in this phase 2 clinical trial, the aprocitentan can reduce the NT-proBNP and also reduce the outflow gradient, and have a very safe safety, and is well tolerated. And this Redwood HCM cohort 4 study just showed the result in May on the HFA Congress, which include the symptomatic non-obstructive HCM patients. And the result shows the aprocitentan can improve nearly 50% the function, and also to improve the KCCQ, CSS, and also the patient, nearly 58% of the patients have clinical reduction of the symptoms burden. So we are just also joining the aprocitentan phase 3 study in China. And in the future, there is some gene therapy is just under the trial, and in the future it can be some effect for this HCM to take a new hope for the treatment of HCM. So this is the optimized therapeutic algorithm from the China HCM guideline. We need to divide the patients into obstructive or non-obstructive, and also combined with heart failure status if the patients have HFpEF or HFrEF. And if the patients have HFrEF, just according to the GGMT of heart failure. And if the patient is obstructive HCM, if there is no contraindication, we first give the beta blocker at the class 1 recommendation, and we also to give the mavacamten class 1 recommendation, and it can be in the future maybe be taken as the first line treatment, even the patients have not been beta blocker in the future. New trial just will be start. And if the patients have also the symptoms, and to give the CCB, if the symptoms just also be continued, to give the such as disopramide or cybenzoline. And if the drug therapy do not improve the symptoms, and next to consider the invasive therapy. If the patients have advanced heart failure, such as have the EF reduction or come into the end stage of heart failure, some patients need to be considered the heart transplantation or LVAD treatment. So just to give the summary of my speech, the HCM is an autosomal dominant heart disease and increase the myosin actin crossbreed formation, leading to the myocardial hypercontractility. And in the clinical practice, we need to make the accurate and precise diagnosis for the HCM, and also to make the risk stratification for sudden death. And for the treatment, we need more new drugs for such as the new SRT treatment to solve the unmet treatment need for the HCM patients. Thank you.